So welcome, everybody. I'm Bobby Duffy. I'm chair of the Campaign for Social Science, and it's a real pleasure for me to welcome you to this webinar on reducing health inequalities from evidence to policy. And I'm particularly delighted for a few reasons, actually. Firstly, this is the first in a new series for the Campaign for Social Science, our Election 24 series. So the Election 24 programme overall seeks to demonstrate the vital importance of social science insight ahead of a likely UK general election in 2024. And while this is the first event, the project actually launched around the end of September, and we've already got lots of content up. So do visit the campaign website. I think the link will be put in the chat shortly to have a look at what's already been done, the written pieces that have already been done. So the project's going to include a series of webinars like this, but also in-person events, more written pieces, and other special events that we'll come up with during the programme as a whole. So the second reason that I'm particularly delighted is we could hardly have started with a more important topic than health inequalities, which are huge and growing challenge in the UK. And so interlinked between different areas. A full understanding across social sciences and beyond is vital to deciding what to do, which takes me to the final reason that I'm so delighted to start with this one in particular, because we have two of the leading speakers that we could imagine to cover this issue, Professor Petra Meier and Professor Trish Greenhalgh. Petra is Professor of Public Health at the University of Glasgow and Director of the UK PRP-funded CIPHER Consortium, which is a hub for system science in public health and economic research. And Petra has a whole range of other roles, which I won't go through now because we've only got an hour for this session. Trish is Professor of Primary Care, Health Sciences, and co-director of the Interdisciplinary Research in Health Sciences Unit at the University of Oxford. And again, a whole range of other roles and accolades for Trish. Just one personal one, Trish did do one of our best ever attended SAGE annual lectures during COVID. So we'll hand straight over to Petra, who's got some slides that she's going to share with us on her section of this, and then crack on. Trish, Petra.
Good morning. Great to be here with you today. As you say, we've got an election year coming up, so my talk will focus on what public policy approaches to health inequalities could look like. I'll show you where we're now, what progress has been made in most recent years, and how social sciences can help. And then I'm looking forward to hearing from Trish and to our discussion a bit later. So whenever we talk about health inequalities, we need to remind ourselves that this is about people's lives being cut short, and that in many cases, this is down to the choices we make as a society, rather than some misguided individuals not consuming unhealthy things or choosing not to work up quite enough sweat. Not only has the UK lower life expectancy compared to many other rich countries, it's also one of the most unequal countries. Life expectancy now is no longer growing. Inequalities have been growing. So to illustrate, this graph here shows the most recent Scottish data for men. To the left, it shows that in the 10% most deprived areas of Scotland, a boy born today is expected to live an average of 45 years in good health, 23 years in poor health, and life expectancy is just under 69. In the 10% richest areas, however, 70 years in good health, 12 years in poor health, and an average life expectancy of 82. What we can see is that the state pension age, for example, will feel very different in rich and poor areas if you look at this. These huge inequalities are first and foremost a social justice issue, but more than that, they're highly relevant for our running of the country and for economic prosperity. I'll give just two examples. So firstly, there are obvious consequences for geographic inequalities in the performance of our labour market. State pension age increases and health inequality declines mean that in many areas, people spend half their working life with chronic health conditions. This translates into productivity loss, staff absence, early withdrawal from the labour market, and risk of poverty, particularly because the jobs available in disadvantaged areas tend to be those that don't have very good protections if you are sick and they're also more physically demanding. It's a two-way relationship. Losing one's job, in turn, is associated with even poorer health outcomes. Second, we've got intergenerational consequences. For example, when parents are sick or disabled, the risk of child poverty is much higher. Also, in disadvantaged areas, young adults take on caring responsibilities earlier and go on caring for longer, which can disrupt education and career progression and perpetuate cross-generational cycles of inequality. Taking a system science lens, as I do, we can see many of these kind of vicious cycles or reinforcing feedback loops, as we call them. What if we were able to effect change? Based on a recent analysis by economics of aging expert Andrew Scott and colleagues, a 1 year increase in healthy life expectancy would be worth £5 trillion to the UK economy. So even purely from an economic perspective, tolerating this level of health inequalities makes little sense. Whilst I find it deeply unpleasant to reduce the experience of suffering to an economic problem, these findings and estimates do help when I talk to someone who's in the middle of an economic strategy refresh. So back to our healthy life expectancy. What's government doing about it? For quite a number of years, the government has had really ambitious health inequality targets that have so far survived several changes in government. It appears in several documents, from the industrial grand challenges to levelling up to the new major condition strategy. The target is twofold, and this is important. It says that by 2030, the healthy life expectancy gap between rich and poor areas will have narrowed, and that by 2035, average healthy life expectancy will have increased by 5 years. It needs to be this twin aim, because achieving a 5-year increase in healthy life expectancy is highly unlikely without drastic improvements in the lower part of the distribution. And I've tried to illustrate here where the solution, what a solution could look like. There has been little to no progress in the last decade. Looking at more recent data, healthy life expectancy is in decline and gaps are widening, a trend that started even before the pandemic. So what can we do? There are no silver bullets. Instead, the rest of my talk, I'll emphasize that substantial and transformative changes are needed across a large number of systems, and that social sciences has a role to play here. Apologies if this picture of a bathtub takes you back to Public Health 101. It's worth revisiting, though, because we do keep getting it wrong. What this illustrates is that to increase years lived in good life, we need to focus on two things: the inflow by the tap. This is about preventing and delaying healthy people transitioning to poor health. The job of good public policy is to create the conditions that help all people stay in good health for as long as possible. And the outflow at the bottom of the bathtub is to minimize time spent in poor health. And for that, you need good health and social care. Currently, there's an imbalance. And if public policy does not stem the inflow, the only two options are for the pool of people in poor health to keep continuously growing and overflowing at some point, or to keep increasing healthcare spending. Some refer to this as failure demand, spending caused by the failure to prevent avoidable harm. If there's one thing I would like you to take away from this talk, it's that we must shift our perspective. Good health can't be solely the responsibility of the NHS. The NHS can't single-handedly fix problems that are caused by decisions in non-health policy sectors. Any amount of investment in the NHS isn't going to help unless we sort out the inflow problem. So, how do we turn off the tap? We've got strong evidence. We know what we need to do. Key modifiable factors that significantly impact our ability to live long and healthy lives include things like access to a high-quality education, employment, good working conditions, financial stability, a safe and decent home, supportive relationships, healthy surroundings, and well-delivered public services, including health and social care. When these factors are in place, people have access to resources, lifestyles, and environments that together promote health. The health inequality link comes from these factors being very unevenly distributed in society. The pandemic and cost of living crisis have further exacerbated inequalities. New poverty, disrupted education and work trajectories, and diminishing resources for public sector services are expected to worsen healthy life expectancies for years to come, and to worsen health inequalities at that. I said there are no magical bullets, but there are a large number of policies that sort of sit as best buys under each of these at different scales of government, like access to affordable homes and equitable access to good education, strengthening communities, raising low incomes, and so on. The Marmot principles offer a detailed framework for achieving these goals. And to be honest, the recommendations of what we need to do have changed very little in the recent decades. So if we know what needs doing, why is it so hard to make progress? In comes social sciences and science in general, or even system science, because what stalling healthy life expectancy and other grand challenges like a climate resilient future have in common is that none of these issues can be solved in a policy by policy or intervention by intervention fashion, or by solely relying on individual level behavior change. If any progress is to be made, it needs concerted and well-integrated efforts by a large range of players and large-scale investments. Time is short, but I will give you a few examples of how I think about the role of social sciences. Asking uncomfortable questions, challenging myths, considering likely future developments, and helping move into a world where health equity impacts are a major consideration in all policies. Let's see whether I can get to all of these, and if not, we can discuss later. So one thing that social scientists are really good at is to ask uncomfortable questions. First, when studying system transformation, one approach is not to focus on levers for change, but on looking at what maintains the status quo. Who or what works towards keeping things just as they are? One thing I'm convinced about, health inequalities can't be solved simply by providing a bit of extra support to disadvantaged groups or areas. We've tried this, and it hasn't fundamentally changed the system that generates inequalities. While additional investment in disadvantaged areas is essential, lasting change will only occur if we address power and wealth distribution across the whole of society. So what counterforces would mobilize if policymakers started to go full tilt on education inequality, or health damaging commodities, or affordable housing, or maybe the greatest threat to all, fossil fuels? Second, do people genuinely care about inequalities, or is it human instinct to hoard privilege for yourself and for your offspring? This is an active area of research, and I don't think we've got the answer yet. The picture is quite messy, but my crude summary would be that yes, people do care about unfairness, but it depends a bit on the factors, like the nature of the inequalities in question and whether they're being seen as deserved or undeserved. And the way questions are framed is really important. For example, people say they care about child poverty, but they don't care as much about maternal poverty. These two are entirely the same thing, but the way you ask the question really matters. Third, we seem to see lots of cycles of action and inaction, social tipping points, which cause yo-yoing between action and inaction. When issues become highly visible, impacting large segments of society, there's often consensus to act. But once progress is made and the problem becomes a bit less visible, we tend to lose momentum. It looks like we can never quite sustain progress long enough for systemic change to become embedded. And this cycle of often quite major investment, following by disinvestment in public services, may be much more costly in the long run than consistent action. The key question for further research is what incentives and disincentives would promote lasting system change towards a more equitable, stable state beyond political cycles? Not an answer I have, but something I'd be very keen to discuss with you. Another thing that I think social sciences has got a real role to play is to challenge myths. Things like, for example, that the aging population drives NHS demand. We know that demand is driven by chronic ill health, and as we saw earlier in the earlier slide, age is not a good proxy for chronic ill health. The graph to the right shows that per capita NHS expenditure is the same for 50-year-olds in deprived areas and 70 in affluent areas. So the idea that longevity is what drives NHS demand is just not sustainable, at least not as easy as all that. I think science has a major role to play in thinking about plausible futures and future resilience. What plausible future developments may shape health inequalities over the next few decades. Nobody knows the future, but we know some things that are likely to come our way: climate crisis, demographic shifts, technological changes such as AI. geopolitical instability seems more likely than ever, future pandemics as well. So whilst there are huge uncertainties about timings and ecological and social tipping points, we can reason about likely impacts on health and health inequalities, and can try to anticipate what we need to do. We can, for example, examine previous technological revolutions, times of resource scarcity, and learn from countries that are ahead in terms of demographic change or extreme weather events. Such reasoning can be in the form of qualitative research, with workshops involving experts in different disciplines to consider the most likely or most serious consequences for health inequality and how to avert or prepare. But they can also be in terms of modelling, similar to climate modelling, where we can quantitatively consider how key social systems that drive health inequalities may respond to these expected future developments. For me, a key priority is to understand what future health inequalities we are locking in through current social, economic, and environmental policy decisions. We know that many of the root causes of the current health inequalities have got their roots decades ago. And in the same way, I would like to ask ourselves, looking back in 20 or 50 years' time, what will we wish we'd done differently now? For example, if I had to guess, then we may come to regret the 26% real term cut to public health funding since 2015-16, given that a healthy life year gained via public health interventions is 3 to 4 times cheaper than a healthy life year gained through medical treatment. And there are many such examples where we know now that what we're doing is possibly not something that is going to be very good for the future. So I think I'll leave it there, just to sort of say health equity in all policies and aligning action across different systems and processes is something that system science is particularly good at. And government actually has a system science toolkit, which is really useful. Encourage you to have a look at. Happy to share the link if anyone's interested. I wanted to end with some questions for you, and you can ask me questions as well, but I thought I'd get there first. So first one was that question about incentives and disincentives. What could promote sustained system transformation and stop that yo-yoing between doing something and not doing something? How can we prepare for future developments that are likely to impact on health inequalities? What can you do, whether you're a landlord, an employer, or maybe an urban planner? What can you do that would make a difference? And what social sciences research would you like to see done? Just in case there's some people here who fund this kind of research, is there something that we're missing? Is there something we should be doing that we're not currently doing? Thank you very much. I'm handing back to Bobby.
Brilliant. Thank you so much, Petra. That was such an excellent overview of the context for this and some of the challenges. Just a quick reflection before we come to Trish. Is really important that you brought in the issue of public attitudes around this, and that's something that more in my Policy Institute at King's role we've done quite a bit of work on, including for the IFS Deaton Review of Inequalities, where we wrote the overview chapter on attitudes to inequalities generally, and the interlinkages in this are very clear. And then we've got ongoing work with an APBG on inclusive growth, which again emphasizes how the public do see interlinkages between aspects of inequality and poverty with people. But just very quickly, I mean, people don't like inequality and unfairness and us seeing us as too unequal, particularly at the top. That is really cut through with people who've seen the top 1% moving away. But it's not top of mind. It's not the most salient issue that comes through. Other issues kind of get in the way, and people have difficulty seeing past the system. We've got strong individualistic tendencies. We've got a strong meritocratic starting point and quite mid-Atlantic in our attitudes in many ways. But I think your point about misperceptions is so important, and us correcting some of those misperceptions, because that is also shaped by how we talk about this and the messages that people get about it. So correcting those misperceptions, really important. And I really took that from your talk there, Petra. That was excellent. Thank you. So I'm going to hand straight over to Trish.
Right. Well, thank you very much, Bobby. Just confirming that you can hear me.
Yep.
Great
good
stuff. That was fabulous presentation, Petra. I'm so pleased you made all those slides, because I haven't made any slides. I'm just going to speak for about 10 minutes, and I wanted to pick up one particular question that you asked in your great presentation, and it was this: if we know what needs doing, why is it so hard to make progress? Now, I'm a medical doctor and I'm also a qualitative social scientist, and I've been interested in policy for a number of years. And my favorite definition of policy is the authoritative exposition of values. And I can't actually find who said that. It wasn't me initially, but I really like the idea that what policy is, it is a bringing into being of a set of values. And I think to answer the question, why is it so hard to make progress? What I'd like to do is have a look at the values that underpin particular policies, particular approaches to addressing inequalities. Because as Petra said, governments of all persuasions espouse the ideal of reducing inequalities. It's not something they say we should keep inequalities. They all want to do it. But the question is, what are the values underpinning the policies that they put in place? And I'm going to talk a little bit about, broadly speaking, socialist policies and then broadly speaking, neoliberal policies. So socialist policies, for example, are built on these kinds of values, and this isn't a comprehensive list, but for example, the value that universal healthcare is a public good and a human right, the value that the state has a moral duty towards vulnerable groups such as the sick, the old, the very young, people with disabilities, people without full citizenship rights, all that kind of thing. The value that there should be a cradle-to-grave welfare state, and the value that reducing poverty is key to improving the health of the population. So broadly speaking, those are some relevant socialist-y values. And I'm sure when we get to the discussion, people will set me straight on the ones I've missed. That's fine. But let's now look at neoliberal values. So neoliberal policies are built on a very different set of values. For example, the value that the private sector does a better job and a more efficient job of running most industries and services than the state does. The value that deregulation and free trade are therefore good for society. The value that government spending should be minimized so it doesn't interfere with these free markets. And the value that, as far as possible, individuals should be free to make rational choices. Now, I'm going to come back to these contrasting sets of values, but first I want to share 3 stories with you, and they're fictional stories, but they're based on real people, and I think they kind of pull together some of the things that Petra is bringing up about the upstream causes of inequalities. You know, that picture of the bath. You know, if we don't do something about the water in the bath and all that kind of thing. So let me tell you first of all about Johnny. He's a 50-year-old delivery driver for one of the big companies, and he's on a 0-hours contract, of course, and he goes to his GP with a painful knee. He had the same problem on the other knee 15 years ago. It's a torn cartilage. The problem is that Johnny can't work because his knee's very painful and it locks up when he drives, so it's quite dangerous. So 15 years ago, when he had this problem in the other knee, he was quickly referred. He had a small operation. He was back at work in 2 weeks. This time, the GP says the waiting list is more than a year just to see the consultant, and an operation might take another year. So he asks Johnny, would you like to be referred privately? And Johnny says, no, I don't have that kind of money. My second story is about Amelina. Amelina is 2 years old. She was born healthy. She's now constantly wheezy. She keeps getting chest infections and she's underweight. Amelina's family immigrated from Somalia. They're living in a small flat in an inner city. It's damp, it's cold in the winter, and it backs onto a major road that often has standing traffic. Amelina's father works in a factory. The family pay high rent to a private landlord. They're probably eligible for benefits, but nobody's explained to them how to claim those benefits. And let me introduce my third character, Dorothy. She's in her late 70s. She's getting frail. Her husband has had a stroke and she's his main carer. Between them, this couple have 6 different medical conditions. Now, they used to have a district nurse who popped in once a week to deliver their medicines and check they were okay. But now the medicines come in a delivery box that gets left on the doorstep. The GP they knew for 25 years has retired, and now they see a different doctor every time. Dorothy's supposed to monitor her husband's blood pressure and send the readings in by text message, but she's not sure she's doing it right, and the messages just seem to disappear into the ether. Now, these three fictional cases illustrate a lot of issues to do with health policy, and I'm not going to labor those too much, but I hope you get what I'm getting at. Now, Petra's already mentioned Sir Michael Marmot's work, and I want to bring in some more of Michael's work, a 2017 paper called The Health Gap. And in that paper, Michael challenged this neoliberal assumption that being healthy is mainly about making the right behavior choices, eating the right food, not smoking, taking enough exercise, and so on. And Michael Marmot cited a list of alternative instructions, and I'm now going to read those out. There's 10 instructions. Number 1, don't be poor. If you can, stop being poor. And if you can't stop being poor, try not to be poor for long. Number 2, don't live in a deprived area. And if you do live in a deprived area, move. Number 3, don't be disabled or have a disabled child. 4, don't work in a stressful, low-paid manual job. 5, don't live in damp, low-quality housing or be homeless. 6, be able to afford to pay for social activities and annual holidays. 7, don't be a lone parent. 8, claim all benefits to which you are entitled. 9, be able to afford your own car. 10, use education to improve your socioeconomic position. Many of these instructions, most of them, relate to things that the individual can't change, of course. And as Petra explained so beautifully, they're all linked to the social determinants of health. Now, to put it another way, many illnesses, especially in the most vulnerable groups, that bottom decile, if you like, could be prevented if we put policies in place to reduce the shocking and widening inequalities that characterize contemporary UK society. Those policies will include, among other things, progressive taxation, a minimum basic income, and security of that income, decent housing and living conditions. I see Woody Khan's already putting questions in the chat about housing. Great, let's pick those up. Humane working conditions, employment rights, high quality basic education for all, a strong and comprehensive social care system, and safe working environments and public spaces. So let's come back to 2-year-old Amelina. She's already got chronic lung disease because day in, day out, she's breathing environmental pollutants produced by traffic, and she's breathing in mold from damp housing. Both these issues are amenable to regulation. In 2020, a coroner ruled that the death of a girl in South London was directly linked to air pollution. If you are the kind of government that thinks that the market works best when people exercise rational choice, you're going to be inclined to blame Amelina's parents for choosing to live in such an unsuitable part of town. But if you're the kind of government that thinks that the state has a responsibility for the quality of air we breathe, you'll probably see the solution more in terms of regulation. Talking about regulating for air quality, this is one of my favorite topics. If those of you follow me on social media through the pandemic, you may be aware of the research evidence on airborne transmission of COVID-19. People catch COVID indoors because the virus floats in the air. Now, recently, the New York Times ran an article called "The New War on Bad Air," and I quote from it: "A century ago, a well-ventilated building was considered good medicine. But by the time COVID-19 arrived, our buildings could barely breathe. How did that happen?" Let me propose an answer to this that's based on values. In the mindset of a neoliberal policymaker, public health interventions are framed mainly in terms of individual responsibility. To prevent you getting COVID, for example, wash your hands, sneeze into a tissue, keep 2 meters distance, and so on. You can even choose to wear a mask if you want to protect yourself. Government's responsibility, for example, to regulate for air quality, is downplayed. I suggest that in this example, there is overwhelming scientific evidence to support shifting the focus of public health to bringing back the core responsibilities of the state. requiring businesses and public organisations to improve their buildings will be unpopular and expensive in the short term, but it could have substantial population benefits for decades. So let's come back to Johnny, our gig economy worker who's been told he can only have his operation if he pays privately. Johnny's story is being repeated up and down the country. There's literally millions of people waiting for a crucial appointment, more than 10,000 who've been waiting for more than 18 months. 13 years of investment have come perilously close to destroying the NHS. Now, if you're building your policies on neoliberal values, that doesn't matter too much, I guess. The market will produce something to fill the gap, and tough luck to Johnny if he can't afford that option. But if you believe that society has a duty of care to its most vulnerable, you should demand that the next government do something to reverse this decline, correct the underinvestment, and restore the cradle-to-grave, free at the point of need service that was Nye Bevan's vision when he set up the NHS in 1948. If we look at the NHS through neoliberal values, it's a business. But through a more socialist set of values, it's a public good. Apart from the good it does for people's health, which I'm not going to go into too much now, it's also the country's largest employer. The NHS boosts the economy by providing jobs, as well as contributing to research and innovation. It produces, or at least until recently, it used to produce a highly trained and highly motivated healthcare workforce that was the envy of the world. But 13 years of wage stagnation, understaffing, premature retirement, and general workforce attrition have taken a heavy toll on the existing NHS workforce. Dorothy's GP, who provided her and her husband with relationship-based 55 years, retired at the age of 55 because he was burnt out. He's been replaced by locums who offer what's known as transactional care, a sort of EasyJet version of a family doctor. GPs are not just the gatekeepers who control access to specialist care, they're also generalists who manage the majority of conditions without onward referral. Relationship-based care from a GP who knows the patient and their family well is more effective and more cost-effective than a more fragmented and transactional service in which the patient doesn't know the clinician and vice versa. Transactional care leads to repeat visits from unsatisfied patients, as well as to over-investigation, over-prescribing, and over-referral. And this leads to higher overall service costs and worse health outcomes. Many junior doctors have chosen to emigrate to places where the working conditions are better. You get protected time for training and the salary is higher and goes further. This trend to emigrate is especially concerning when we factor in the changing demographics of this country. More people are getting old, fewer people are being born. This situation is unsustainable. We can't solve the hemorrhaging of our skilled workforce by poaching workers from other countries, nor, frankly, is it ethical to do this. We have to address retention of NHS staff, as well as recruitment, starting perhaps with junior doctors and nurses, but going right across every type and grade of staff. We need to give all our NHS staff the clear message: we value you, we care about your well-being, we want to keep you, we will train you. And we need to strengthen the NHS itself rather than fragmenting its activities and contracting them out to private providers. And yes, this will cost money in the short term, but it's likely to prove cost-effective in the longer term. Now, I haven't seen any of the political parties' manifestos yet, but with some of the statements being made by both ministers and shadow ministers, I am worried that both the main political parties are building their policies on, broadly speaking, neoliberal values. I'm worried, for example, that both parties are talking more about individual behaviour change, such as people taking more exercise or eating healthy foods, than about the upstream structural determinants of health. Where are the draft policies, for example, to address what Boyd Swinburne calls the obesogenic environment that's linked to corporate control of the food supply chain? I'm worried that both main parties are framing the fundamental problem with the NHS as inefficiency, and that yet another restructuring or corner-cutting gimmick is going to generate the savings needed to refloat the NHS without increasing taxes. Poorly qualified, poorly trained staff might be cheaper per hour, but they can't do the same jobs to the same standard as more highly trained professionals. This approach often results in extra workload, reduced productivity, and more inefficiencies. I'm worried that both main parties are viewing new technologies in deterministic ways as shiny modern fixes for problems which in reality can be traced back to structural determinants and which need human, societal, and political solutions, not just technological ones. Technologies can and do save lives, and sometimes they make processes more efficient and save money. But as in the example of Dorothy struggling at home with a blood pressure machine, a dependent husband, and a mobile phone, technologies can create the illusion of care while dehumanizing the patient and contributing little. Let's face it, what Dorothy and her husband need is a return of their district nurse. So here's my bottom line for political parties in election 24. First, you might want to revisit the core values on which your party was founded. You may come to the conclusion that it's okay to care about the sick and vulnerable. You may conclude that it's okay for the welfare state to be a safety net. Second, ask yourselves how you will attend to the vast majority of upstream causes of ill health, which lie outside the healthcare system. For example, you may want to take bold steps to reduce poverty and improve equity of opportunity in every aspect of society. And third, you could ask yourselves whether you view the NHS as a business or as a public good. If the latter, you should be promising to renew and strengthen its core services, to value and invest in its staff, and resist the temptation to fragment it and outsource its work. If you go down this route, of course, you'll need to be honest that all this will cost money, and you need to make clear what people are going to get for that investment. So having raised the issue of how we're going to pay for all this, I'm not going to try and answer it. I think it's about time to stop for discussion. So I'll hand back to Bobby.
Brilliant. Thank you so much, Trish. Great to get those vignettes in there to make it really bring it home, the differences that we see across different life experiences. So just for me to say thank you very much to the team at the Campaign for Social Sciences and the Academy of Social Sciences for putting this together. Really great stuff. To thank you all for coming and staying with us today. And then, of course, finally, to thank our excellent speakers today. Really, really great session. The video from this will be on the website, of the presentations at least, will be on the website. And do look out for more content on the Election 24 Hub, including upcoming events, one on migration policy next week, and then many more to come beyond that. So do look out for that. So finally from me, just thank you, everyone. Have a great day.